Good afternoon. I am Stephanie Blau, Chair of the FPA Young Patients Committee. Later today, you can attend a session to learn more about the YPC, but now I'd like to introduce you to Dr. Richard Zimmerman, Professor of Neurosurgery at the Mayo Clinic and member of the FPA Medical Advisory Board. A reminder, please type your questions for Dr. Zimmerman in the chat. Dr. Zimmerman, I'll turn it over to you.
Oh, Stephanie, thank you so much. And it's an honor to be here. It's a pleasure to be here. And I really have to say a great thank you to the work that Allison has done, the work that David Myers has done, and Dr. Brown in organizing this conference for the patients. It really, it's always beneficial to learn more about what's your health and what's bothering you and what you're afflicted with. And certainly affliction is a good word for trigeminal neuralgia. So hopefully I can give you some information today. I will tell you that we have multiple surgeons during the conference today and tomorrow. You will hear no shortage of difference of opinions, but we're always right if you ask us. So never short of confidence. But no, I think we'll get into some details and you'll have plenty of chance for questions. So I think we're ready to go now. If we can start with the slides. Great. Hopefully you can see the slides that are up there. I will be talking about microvascular decompression and a little bit about what's old in order for you to understand what's new, and then also what's coming and what hopefully will be next. If you've been at the FPA conference before, some of my slides will be repeats, if you will. You've seen them because they are very effective teaching tools. And my goal today is to help you understand and to learn a bit about facial pain and MVD. So I have a lot of acknowledgments. I work in a multi-specialty group practice at Mayo Clinic, and I have headache experts, facial pain experts, other colleagues in neurosurgery, support staff that's outstanding, my two nurses who have done so much to help the facial pain community here, and then my colleagues in practice. And I think it's so important that you have a team to help the facial pain population because it's not easy to always have the right answer, and you need a trust of individuals that will contribute to a solution for any individual patient. Some disclosures really quickly. As noted, I'm on the Facial Pain Association Advisory Board. I've been a member for several years. I do work on serve on a governing board for Neuropathy Action Foundation, and I have some consulting agreements with some industry, none of which have to do with trigeminal neuralgia or facial pain management, period. So my objectives today, I'll give you an outline of the evolution of MVD. I will show you some variations where I think MVD could be going, where it is today and potentially in the future, at least certainly in my practice. And then some innovations in imaging and concepts in diagnosing and treating trigeminal neuralgia. So the one thing I have to say is I am a surgeon. I have a surgical bias towards things. That's what I am an expert in. However, I do think that it's a disservice to patients to continue to harp on the phrase and repeat the phrase only after medical failure. Certainly the young patients that have trigeminal neuralgia and even the elderly patients that have trigeminal neuralgia, if you are taking medication, you're managing the problem, you're not curing it. And we would all like to see a cure. And I'm not saying that surgery is always a cure, but if you don't offer the opportunity for a surgical evaluation or tell the patient there is a surgical treatment option for this, you are not allowing the patient to make their decision based on their personal preferences. And that's not fair to the patient. So I really think that it's very important that when you discuss trigeminal neuralgia with any provider, neurology, primary care practitioner, or neurosurgeon, that it's a balanced discussion. I think every surgeon would discuss medical management as well as surgical management. I think it's appropriate that any medical doctor discusses surgical management as well as medical management, and without the details as appropriate. So I don't discuss details about medication management other than suggest it is an option, and it can be a good option. Although lifelong commitment to medication that you fear missing may not be the best option for you. So give the patient freedom of choice. And I don't agree with waiting till failure because I just don't think you're giving the patient all the choices that are really available to the patient. Enough said of my surgical bias. In order to understand what's happening now and in the future with MVD, I think you should understand the characterization where the pain of trigeminal neuralgia has been described and who is described. And Dr. Brown did a nice job of talking a bit about the different words in characterization. There have been documented descriptions of trigeminal neuralgia by notable physicians, John Locke and Nicolas Andre. They talk about the painful condition of the face, and they describe tic. Where there's the contraction of the face with painful attacks of TN. But John Fothergill, who was not a neurologist, was a primary care provider, general practitioner, had amazing, after 16 patients, described TN that I think so many of you will appreciate. The pain comes on suddenly and is excruciating. It lasts but a short time, perhaps a quarter or half a minute, then goes off. It returns at irregular intervals, sometimes in half an hour, sometimes there are 2 or 3 repetitions in a few minutes. Eating will bring it on in some persons. Talking or the least motion of the muscles of the face affects others. The gentlest touch of a hand or handkerchief will sometimes bring on the pain. This is a very astute observation and truly doesn't describe perfectly every aspect of trigeminal neuralgia, but you have to realize the insight that Dr. Fothergill had, and he really was probably the best describer of TN at its early discovery, if you will. Now, there are precursors to MVD surgery, and Dr. Brown mentioned some of these. The ablation techniques, which occur in the periphery of the nerve. So, as the nerve leaves the brain, it travels for a short segment, as you know, the nerve root, and goes to that Gasserian ganglion. That's where the cell bodies and the nucleus of the cell is. And then after that, as it goes to the face, it becomes more peripheral. So, the ablation techniques typically attack the peripheral part of the nerve for the most part. That's certainly any of the mechanical ablation techniques. Radiosurgery does go more towards the central technique, and the surgeons that are involved in central technique treatment have been our neurosurgical colleagues. They evolved from some of the techniques that cut the nerve or damage the nerve partially. And that was, so to speak, the early treatments of trigeminal neuralgia from the neurosurgical perspective. The initial observation, so Dr. Walter Dandy observed arterial compression on the trigeminal nerve during an associated surgery, but not for TN. And then he proposed a theory that maybe it was this blood vessel that was causing TN, although he didn't do any surgeries specifically with that in mind. However, I think everybody knows who Peter Janetta is if you belong to this association. And he was the first one who described the operation to do a vascular decompression for trigeminal neuralgia, not some other posterior fossa disease, and published this in 1977. And this is the beginning of our MVD story. So really what Dr. Janetta did surgery for and what Dr. Dandy described is this. This is the brainstem down here. This is the trigeminal nerve root as it leaves the brainstem. And this is a blood vessel, an arterial loop pressing the nerve. This is arterial compression, decompression, compression, decompression. So fairly obvious and straightforward what is being discussed when we talk about that contact. Now, it's interesting if you go back and research what Dr. Janetta started the first time he did his microvascular decompression. He talked about moving the blood vessel off the nerve because that was the initial region, but he also carried out a partial nerve section. So the portio major is a sensory portion of the trigeminal nerve coming out of the brainstem. So the brainstem is here and it's going to the face towards the right here, but he cut the nerve and he caused, as you would expect when you cut a sensory nerve, hypalgesia and analgesia. So you don't feel pain or you don't feel anything, or you feel unusual sensation in the face in the corresponding area to the nerves that he damaged. So the previous, I mentioned this before, the previous neurosurgeons who did treatment for trigeminal neuralgia would partially cut some of the nerve. And as you make it less sensitive, sometimes you can help stop triggering the painful attacks. But what's interesting, what Dr. Janetta found was when he did this in his initial patient, he had this area of analgesia in the patient's face, and he's outlined it here in his publication. But what was more interesting was that this is the distribution of the patient's tic. The trigeminal neuralgia was in V1 in his patient. And what he noted was that this tic went away with the vascular decompression. So how did the vascular decompression and the unrelated nerve section have an impact on this part of the trigeminal nerve? So he hypothesized that this possibly definitive procedure, release of the artery without nerve section, is planned for his future series of patients. And that's what Dr. Janetta's career has been about. Pursuing this vascular decompression, avoiding nerve section, avoiding nerve damage. And that is the basis of microvascular decompression. And enough, you can't say enough things about Dr. Janetta and the work that he did for the trigeminal neuralgia population and for all the physicians who ever encounter a patient with this. His personal quest to educate the world about TN really has made a huge difference and has affected every neurosurgeon that has trained since his time. Now, I do want to speak a little bit about this root entry zone because it is very pertinent to where we look for vascular compression. And we'll always talk about this root entry zone, and our surgeons will always talk about this root entry zone. And it's interesting when you look at future things, where things are going, and possible research, it's important that this is an understood component of what's happening at the root entry zone. So, a little basic neuroscience education. In the brain, when the nerves are in the brain and spinal cord, they're part of the central nervous system. In the central nervous system, the nerves, as we discussed previously, have this insulation, just like a wire has insulation. That insulation is called myelin or myelin sheath that covers the nerve and helps the nerve conduct impulses normally. The cell that produces that is called the oligodendrocyte. And that cell in the central nervous system, in the brain, covers the nerve. Once the nerve leaves the brain and goes out to the face, in the case of the trigeminal nerve, or the rest of the body, they still require insulation for the nerves to conduct electricity effectively. This peripheral nervous system, once the nerve leaves the brain or spinal cord, this is now covered by a different cell. They have a myelin sheath, an insulation sheath, but it's created by a different cell. So there's a transition between the central nervous system myelin or insulation and the peripheral nervous system insulation. And this photomicrograph, not of a patient with TM, but of a normal nerve, shows brainstem and a special stain that stains the oligodendroglial myelin. You can see this is where the nerve exits the brain. This is the root entry zone. And there's a transition to the Schwann cell myelin, which stains differently. So there's something about this area, both peripheral myelin, Schwann cell myelin, which is one area of future research, and oligodendroglial cell myelin, or central nervous system insulation. That's a different part of the root entry zone. And I think as we go forward and do research to try and help patients who have lost myelin that haven't been fixed by any surgical procedure, do we have knowledge enough to attack or fix this myelin or this myelin? And I think that's an important consideration for future research work. Now, interestingly enough, when Dr. Janetta described his microvascular decompression experience with about a 4,000 plus cases reviewed, he described his technique in these drawings, which was summarized in this article, The History of the Janetta Procedure. And Dr. Janetta talks about opening up some of the arachnoid and then using a substance, this wad of Teflon, to help lift, mobilize, and then isolate the blood vessel from the nerve below. Now, this is great at the time, and you can see from the quality of this drawing compared to art today, and the quality of this picture was from Dr. Janetta's time, that the technique of intraoperative visualization and surgical skills has evolved since 1967 to quite a degree. And I think that's what leads us to say we can do perhaps better than this, and I'll explain why. So we talk about microvascular decompression, and the nerve and vessel, whether it be artery or vein, are somewhat isolated now. Usually it's an artery. But what about doing it differently? So if we know we can isolate this with the wad of Teflon, why not completely isolate it and leave the nerve alone? What I would call a microvascular transposition. Because if you're trying to get the nerve to be unencumbered, not to have any pressure, not to have any pulsation, you don't need to have anything touching it. This is a video, if I can get it to start, because my private chat won't go away. Let's see if I can do it here. So this is an exposure going to the trigeminal nerve. You may have seen this video before. I think it's a very useful teaching video. But under the surgical microscope, you'll see that the brainstem is going to be on the bottom of your screen. The nerve coming out of the brainstem is going up towards the face. And clearly behind the nerve, you see this blood vessel that was poking through the nerve to the point of almost piercing it. And if you go back here, you see it's almost going through the nerve. But what you can do with current surgical microscopes, which are very high quality optics, great lighting, which Dr. Janetta had not quite the same thing in 1966 and 67, you're able to move the blood vessel and transpose it to a new location. Now, the challenge is if you just push the blood vessel out of the way, it's like a garden hose in the wintertime in the cold climate. You push it to the left, it's going to bounce back to the right. And what's doing that, not only some memory in the blood vessel wall where there's some muscle, but this filmy stuff attached to this blood vessel, which has no relation to the nerve, but this filmy stuff is called arachnoid, and it suspends the blood vessels inside the brain. You can see me teasing this arachnoid or cutting it off the blood vessel. And once you do that, you are able to move and relocate the blood vessel and leave it alone. And now you can see without doing anything, it doesn't bounce back against the nerve. So why would you need to put Teflon in there to keep the blood vessel up the nerve? To keep the blood vessel in this location, however, you can augment this new position. You like to use a biologic adhesive that's absorbed and broken down by the body of products that are normally found in the body, cryoprecipitate and thrombin. Thrombin comes from blood vessel walls when they're injured to help blood clot so they don't bleed. Cryoprecipitate is a normal component of blood, and the body will break this down, but form new arachnoid adhesions, new filmy adhesions that suspend the blood vessel up here and keep it from moving against the nerve. So in terms of what's new, certainly in my practice and in my mind is, why don't we get the nerve totally unencumbered? Why do I need anything touching the nerve at all? If the operation is called decompression, which Dr. Janetta pioneered, I think we can perhaps innovate and do a bit more than just put Teflon in between the nerve and the blood vessel. So now to make sure that it stays there, though, you can take it a step further. And this is the same operation, a different patient, though. You'll see this is in the last stages of applying some of this adhesive, this glue that I like to use. But you'll see what I do is I take some saline irrigation, and I'm going to bring in a syringe. Here's the nerve decompressed. You can see where the compression used to be. I'll take a syringe and I'm going to irrigate fairly aggressively to make sure this is not going to slip and come back in contact with the nerve. Now, this is not just a one-off. So if you will, in the famous instance of case after case after case, I can show you isolating blood vessels from the trigeminal nerve, lifting them off over and over. This is an interesting case. This is the loop all the way down below the trigeminal nerve. And you can see slowly you're able to mobilize this blood vessel. Certainly, if you know the blood vessel, you know your neuroanatomy, and you're familiar with how to move blood vessels. And my particular practice was started by my fellowship, where I had a specialty fellowship in microvascular surgery, including how to move blood vessels when you need to for aneurysms, AVMs, and MVDs. You can completely mobilize this away from the nerve, and again, glue it up to the top surface over here, away from the nerve. And you can do the same thing again, repeatedly, able to mobilize the blood vessel off the nerve, mobilize the blood vessel. And these are examples of the most common cause of vascular compression. This is a superior cerebellar artery. And so it goes to say that you can identify this on a preoperative MRI, as Dr. Brown was discussing. You can figure out which blood vessel it is, and you can plan to do this without needing Teflon. We actually, in the section of this journal, Operative Neurosurgery, under the area called Innovations, we talked about our experience without Teflon. We looked longitudinally over patients' outcomes, and they certainly had a very good 5-year pain-free rate of 94%, even up to 10 years, 83%, which extended actually out to 15 years with the Teflon-free microvascular decompression. And you can see here, this is how effective they are. This is out to 15 years, over 80%. I think when Dr. Brown showed you the statistics for MVDs, it was in the mid-70s for, in general, MVD success over a 10-year period of time. So I don't think that Teflon per se is a big problem, but I do think it's not a mandatory part of microvascular decompression. And I do think you can do the operation without it. And I do think there are advantages of doing it without it for the following reasons. When you have patients that have recurrence, this is an MRI, this is the pons, the trigeminal nerve is here by the yellow arrow. This is the trigeminal nerve. The trigeminal nerve, these are just adjacent cuts. This material here is foreign. This is all Teflon. And you can't, you have to a hard time convincing me there's no pressure on this nerve when there's this large foreign body in place. Even if you put a small piece of Teflon, this is a side view, here's Meckel's cave, you can almost see the nerve going to V1, V2, and V3. A small piece of Teflon still causes compression because this is the normal side, and this is compression of the nerve at the root entry zone by a foreign body. And we can discuss all day long about pulsation, how there is or is not transmission of pulsation from an artery through the Teflon to the nerve. If you can do the operation without this foreign body, I think that that would be a better way to go. And this is really why. I'll run through this video. This is what someone's putting in your brain when they do an MVD with Teflon. Here's the trigeminal nerve. This is a redo for recurrent trigeminal nerve pain. And this is just to show you what it's like when you try and remove some of the Teflon. It's a very tedious procedure. But the most interesting thing is this Teflon's supposed to be quote unquote non-stick. Well, maybe in your kitchen and eggs, it's non-stick. It does stick to the nerve and to the brain. It can be teased out. And if you advance through the video a little faster, you'll find that you can actually pull it off gently if you do strand at a time. It looks like you're taking out a hairball, but you're slowly able to mobilize the Teflon and take it off the nerve and take away the pressure that's being induced by this foreign body that you're introducing into someone's brain. Now, this is a little different example. Same thing, a redo for recurrent trigeminal neuralgia pain. Trigeminal nerve is down here behind this mass, which is, again, Teflon. So you'll see isolating this from the nerve is quite tedious. There are quite a lot of adhesions and scar tissue. But eventually, you can establish a plane between that. You see the vessel that it tried to isolate before, perhaps wasn't the best isolated. But through microdissection techniques, you're able to isolate, mobilize, and develop a plan for relocating the blood vessel that's still pushing on the Teflon, pushing on the brain through microsurgery. But even more importantly, this foreign body that's stuck to the nerve can be removed. And you can see these little fine filaments that look like the last picture, although these are a bit more consolidated. This Teflon was rolled into a ball before it was placed. It was a thicker wad than the previous case, but eventually you're able to separate it out. You can find the normal nerve, develop a plane, and remove this foreign substance from someone's brain. So ultimately, you get to cut the last few pieces off and you're able to take this out. And there's the trigeminal nerve without anything compressing it. We want to mobilize the vessels. After that, the vessels were mobilized and glued out of the way as well. Finally, again, doing surgery with Teflon has some downsides. This is a slide. My apologies for the slides here. This is a slide of that foreign body that you just saw removed. These are pieces of Teflon under the pathologist microscope. This is what's called a giant cell. It's made of multiple multinucleated cells come together, and it's an inflammatory response to a foreign body placed within your body, a foreign object, a foreign substance. This is a typical response. These are birefringent, fancy pathology slides that show the foreign material. But what I want to do is give you some homework. And what I challenge you to do is go home after the conference tonight, go to Google or Bing or any search engine you like, enter Teflon granuloma, and you see what the literature has about Teflon granuloma, and then ask, is that the right way to have your surgery done? It has worked wonderfully for numerous years, since 1967 in Dr. Janetta's article. It has worked and it is effective. I just think if you want to move forward, what's next, what's new, is thinking about doing vascular transposition so you don't have to put a foreign body. Even if it's only a 5% complication rate, 10% complication, 2% complication rate with granuloma formation and recurrent pain, why use it at all? In my prior life, so to speak, early in my career, I was the medical director of a hospital and I was the chair of safety and quality. And preventable harm was a big concept in taking care of patients. What can you do to prevent harm? Well, if I can not use Teflon, I won't get a Teflon granuloma. So to me, that's prevention of harm. A couple of quick stories. This is a patient who had, again, a piece of Teflon in. Just another quick video. This looks very similar to the first case I presented where this Teflon is in there. There is no dose response curve. Putting in more Teflon is not more effective than putting in less Teflon. But in removing the Teflon, we found what the prior two surgeries in this patient didn't reveal. There's a blood vessel coursing directly through the nerve. This is a Doppler microprobe. It tells you the rate of blood flow, if it's an artery or a vein. In this case, the blood vessel coursing through the nerve was a vein. It's able to be coagulated. After removal of all the Teflon, carefully cut, preserve the nerve its entirety, and then go to the back end and pull. You can see down here to slide out. That's the vessel coming out the backside of the nerve to leave the nerve unencumbered without any compressive. So hopefully going forward, we'll begin a greater discussion of what don't we have to put into the brain to achieve vascular decompression or microvascular decompression. I want to discuss a little bit in the future about imaging for trigeminal neuralgia surgery, and hopefully some of the things that come up in the future as a mainstay of treatment. Everybody is familiar with the MRI. I think if you've been to this conference and you've listened to Dr. Brown's nice presentation, obviously this is an MRI, axial images. You can see the patient's eyes at the top of the screen. I've used this slide before. To give you an orientation, this is the right side, this is the left side, but I'm going to do a little bit of a blow up here, magnify the images. But again, trigeminal nerve is shown by the yellow arrows in this view. This is an old MRI where the spinal fluid is black, and the new higher resolution images show the spinal fluid in white and the blood vessels and nerves in shadows. But I wanted to show you how radiographically we view these blood vessel loops and why we call them a loop. Here you can see this white line, and if you image a loop through the bottom of the loop, in a tangent, so to speak, you will see that the representation on an image on one slice is a solid line. That's the trigeminal nerve root and the root entry zone. Now let's look at the next slice up on the MRI. Now you see two dots on the trigeminal nerve, which is here. So what's happening there is the plane of imaging has been changed. You slid up, so to speak, on the MRI. And now it cuts through at two areas and shows you two dots. And this is how, with a three-dimensional representation on an MRI through single pictures, you can figure out, okay, this is a blood vessel loop that's pressing on the nerve here. You can see indentation as the nerve heads towards Meckel's cave and then out to the face. Now, in addition to that, we've tried to use movies. You'll see, I'll show you this movie twice. This is the normal trigeminal nerve on the patient's left side. Again, CSF is outlined in white. It's very nice. Now we'll look at the right side, and you look at the vascular compression that you can see two blood vessels, two dark dots that are indenting the nerve, causing clear-cut vascular compression. Now, while we've tried to use these movies, I haven't found movies to be much more beneficial than the still images in this view. However, this is unique, and you may remember this from a prior FPA conference. Now, this is a view the surgeon never has. This is me walking around the lab with a holographic imaging device called a HoloLens on my head, and a patient's images have been digitized and put into this format where I can walk around the brainstem. This is the front of the brainstem. No surgeon ever sees this during a microvascular decompression. You can see the relationship of the artery to the nerve and anything else that you decide to place in the digital format. But it's very nice because I will take a stroll, if you will, and I'll walk around the side in preparation for surgery to see what's on the front of the nerve, what's in the front of the brainstem, and what's behind. How difficult will it be to mobilize this artery? So this three-dimensional stroll, if you will, the holographic imaging is one of the things we've also worked on to try and see, will this help us with trigeminal neuralgia surgery? And it certainly gives us a view that we never had before, the front of the brainstem, because we're always looking at the back of the brainstem when we come in to do the surgery, or the side of the brainstem. You can see the unaffected side, the blood vessel and the nerve are nowhere near each other. So this gives us another way to look at imaging in preparation for surgery. More recently, we've developed a relationship with a company called Surgical Theater, and that takes images and puts it in a three-dimensional viewer that allows image manipulation. The goal here is to do a virtual surgery by going through the opening behind the ear, and you will see we come upon the trigeminal nerve and the blood vessel that compresses it. Again, this requires digitization. This digitalization is now automated process. Doesn't require a person to do it. You just have to tell it what the structures are. It doesn't know that, but the system will draw out or digitize from MRIs and CT angios where the bone is, where the vessels are, where the nerves are, in order for you to assist in planning an effective surgery. And you get to do a virtual craniotomy walkthrough, again, having views that you would never have in the actual operation, but to use this, so to speak, augmented reality to plan your trigeminal neuralgia surgery. So again, going forward in the future, we have to look for things besides the standard microvascular decompression. And what happens besides a standard superior cerebellar artery compressing the trigeminal nerve? And we know that there are other arteries that do that. Vertebrobasilar ectasia does that, and other branches off the posterior circulation will cause vascular compression. But I do want to point out a couple of cases that are quite interesting and that your surgical team need to be aware of in the decision making to recommend surgery, and more importantly, for the surgeon to be aware of to prepare themselves to do the surgery. So this is a 30-year-old right-handed woman, a nurse, who at age 20 had her first onset of symptoms, fairly straightforward. Every episode lasted between 3 and 5 minutes. She had the unfortunate common occurrence of having some teeth pulled, only made her pain worse. She did go to see a surgeon, an oral surgeon who was familiar with trigeminal neuralgia, and began appropriate initial management. She did great initially, stopped her meds, pain came back, started her meds again without any benefit, but then she became dependent on increasing doses of medications, added multiple medications, and at this point really was not being effectively managed. She came to see me for surgery, and this is what her images showed. Again, the pons is here. You can see Meckel's cave is over here. The trigeminal nerve is this segment here on the patient's symptomatic right side, the asymptomatic left side. This is that CIS or Fiesta high resolution T2 weighted image that we like to see for surgical planning, but you really can't see much here. I can't say that I clearly see a blood vessel here. This is a T1 weighted post-contrast images where it highlights blood vessels, and you may see a little bit of a bright density here and maybe a little bit of a curve here, suggestive of some enhancement, a small vessel there. It's very hard to say that that's there, but note this large black object here and here, and this is bone. Bone on MRI, cortical bone, hard bone, if you will, is very dark on MRI. And the path that the surgeon takes is this way to get to the root entry zone to do microvascular decompression surgery, takes this way to get to the root entry zone, but this is in the way. So how do you address that? There's the trigeminal nerve. And again, there's that blood vessel that might be there, but it's kind of a soft call, may not be called by a radiologist, and it's hiding behind this mountain if you're coming in from this direction. This is the side view of the same patient. This is Meckel's cave. And you can see there's really no space between the brainstem. There is no trigeminal nerve segment that you can really visualize here. This is not Teflon. This is nothing. This is the patient's de novo state, hasn't had any surgery. Now, again, compare this to this patient who has a long segment of the nerve in the trigeminal cistern in the space, the spinal fluid space running from the brainstem to Meckel's cave. And compare that to the patient at hand, the case I'm discussing, and very, very, very short segment here. Look at the side view. Again, here's a nice stretch of trigeminal nerve vascular contact here, but our patient here has what I've called a short cisternal segment. This does require a bit of a different surgical approach than typical to address what do you do when you come to this, because if you try and get around this, you're going to compress or retract in the brain at an excessive degree that will potentially cause hearing loss or cause some swelling of the brain or brain injury due to excessive retraction. This is the actual surgical photos from that case. This is the beginning of the trigeminal nerve just as it leaves the brainstem. You really can't tell where brainstem ends and or trigeminal nerve begins. Here is that bony mountain, if you will, that bulk of bone that interrupts your view. And you try and see behind it, you really don't see anything past you. Maybe there's this vessel, but just doesn't really press on the brainstem at all. And I'm not even sure it's on the trigeminal nerve yet because the trigeminal nerve is just beginning right under this bone edge. So these pictures are maybe a little hard to identify. This is a very sharp surgical microscalpel, so to speak. You can cut away the dural lining over the bone. This is that bony mountain that I talked about before. This is another surgical instrument, peeling away the dura to make a protective sleeve around this that allows us to take a 1 millimeter drill and drill off that bone. When you drill off that bone, you can cut the little dural envelope that was your protection with these micro scissors. And once you do that and get beyond that, lo and behold, there's vascular compression at the root entry zone. Again, you can test with the microdoppler to make sure this is an artery or vein. This happened to be a vein. These are two tips of a bipolar coagulator. This will send a little bit of current only between the tips and will just coagulate that vein down to a little thread without damaging anything nearby. You can take the micro scissors again and cut that vein. And this is the impression that you had at the root entry zone of the trigeminal nerve by that vein. So I can't imagine in this small space how you would ever insert Teflon and not have more compression than you started with. We did a literature search and found that this petrous endostosis, a fancy name for that bony mountain, has been written about before. Hugh Cockham, Dr. Cockham is a British physician, a neurosurgeon, and he has seen a lot of these cases and done it. We found that it occurs a lot in younger patients, and he has found that in his experience, it has always been venous compression, like in the case I just described. Their case description and the images they showed show a very significant bony endostosis, or bony protuberance, on the way to the trigeminal nerve, but they had a reasonable segment of trigeminal nerve at least. Our case, we had a lesser bony endostosis, but a really short cisternal segment. Another patient, 31-year-old, young people with trigeminal neuralgia, terrible pain. I'll go through the image quickly. Here's the short cisternal segment. If I can go back a little bit, it's very hard to see what's vascular compression in here, much as how would you insert Teflon in there. And he also had a short cisternal segment, same as the other patient. So we've come to describe, in terms of preparation for surgery, patients that have both the short cisternal segment and or petrous endostosis, because you have to be prepared to drill away some bone. You have to be prepared to use a microdoppler. You have to be prepared to investigate what's here and prepared to have a treatment plan that does not include introducing anything foreign into the brain. So I think I'm getting pretty close to being at the end of talk in terms of time, because I want to leave a lot of questions, the opportunity to be asked. So obviously, these are always the nice cases when you can have a nice big juicy vessel and have room. But again, even large vessels can be transposed up to the vertebral artery, and ectatic vertebral arteries can be transposed and glued with fibrin glue. But I'll close by making one advocate for MVD in the future. Again, our goal as neurosurgeons, the optimal goal, as Dr. Brown mentioned, the best outcomes come from microvascular decompression, predominantly because we attack the cause of the problem, the root cause, the pun is intended, the root cause of the problem, and take away vascular compression when that's causing your trigeminal neuralgia. And when you damage the nerve, you have complications. You can have visual loss from the V1 distribution, and you can even have, in any case where you cause damage to the trigeminal nerve, you run the risk of a herpes simplex keratitis. Herpes simplex is a ubiquitous virus in the human body. And if you damage a trigeminal nerve, you can have an eruption of blisters or little pimples. If that ever happens to you, regardless of what you had done, MVD, glycerol, gamma knife, anything, you should contact your surgeon or provider immediately, because you need to be treated for that eruption before it causes a more significant problem. So I'm trying to get done on time. I do have two questions. I've asked this one before. Tic douloureux is A, part of the song Skip to My Lou. B, is it the same as hemifacial spasm? No, that's a different disorder of the facial nerve, although related because it's also caused by vascular compression. Tic douloureux is a painful noise when you watch. Well, that's a kind of nice pun, but it's a bad tick tock. And then tic douloureux is facial pain accompanied by wincing or grimacing, because when patients get their attacks of pain, they do cringe, which is understandable. Question number two, a little more provocative. When you consider surgery for your trigeminal neuralgia and you're thinking about microvascular decompression, will your decision be transposition and think about a Teflon-free MVD? All right. Thank you very much. I think I've finished just about on time, and I hope there's enough time for some questions.
Oh, thank you so much, Dr. Zimmerman. That was a great presentation. We do have some questions on here, even though you did so great on sharing information with us. You mentioned that Teflon is commonly used in a classic MVD surgery. How did you come about performing all MVDs without Teflon?
That's a great question. I mean, obviously, that's pretty much the heart of a lot of my presentation. And I was asked to talk about what's new, perhaps, and what's the future. So just like Dr. Janetta took the cases of all the surgeons before him were doing these rhizotomies, PSR, partial sensory rhizotomy, cutting the nerve. And he felt it was necessary to innovate and take it to some different level. And also, he recognized that the contribution by Dr. Dandy of seeing this blood vessel pressing on the nerve. So he decided to try an operation and move the blood vessel off specifically to treat TN. And that was an innovation that was met with a lot of skepticism. He had to fight a lot. He was, I won't say ridiculed, but he was certainly criticized enough about, oh, that can't be the case. And yet we all know that he was correct, that is the case, not in every single case of trigeminal neuralgia, but in the majority of our cases. And we have a lot to thank Dr. Janetta for. But in that same vein, when I did my fellowship, I was doing a lot of surgery in the subarachnoid space, cutting a lot of arachnoid, moving blood vessels as they needed to be moved. And when I started to see patients with trigeminal neuralgia, I had to pause and say, why can't I do this for all those patients and not introduce something foreign in their head. At the time I began doing this, maybe 25 years ago, there wasn't the literature on Teflon granuloma that there is now. But again, taking that piece of evidence in hand, as well as saying, hey, this is a very viable surgical procedure that if you're a talented and experienced surgeon that can do surgery under the microscope or know how to do arachnoid dissection, you can do this operation very simply. I don't have a thing against Teflon per se. You can use it to potentially make a blood vessel stay out of the way if you have to. I just prefer to avoid it if I can. There are certainly cases where I have had to use Teflon or something to keep a blood vessel out of the way. Some people use aneurysm clips. Some people use slings of either muslin or cotton. But if I can prevent putting anything that's not really part of the human body into the human body, I'd like to finish up that way. Certainly in the intracranial space. I know we use plates and screws and different compounds to close the hole in the bone, but that's outside the head. Inside the brain, that's pretty expensive territory that I'll leave natural as much as possible.
Great. Thank you. Is recovery time similar when using Teflon or not using Teflon with MVD?
I think that would be the same. I don't think once you get the operation done, your recovery in expert hands, and I mean the expert nursing hands, because while the surgeon operates and does the same operation every time and does a good job, your care post-operatively will determine your recovery. And I think it's important that you have a good team, that you have a good nursing unit. We actually don't send patients to the ICU because our neurosurgical floor is so familiar with TM patients that they get to observe them closely and they get monitored very closely, like, so to speak, almost like a step-down unit. But it's the care afterwards that helps their recovery. But recovery-wise, I don't think there'd be any acute difference. I think the long-term differences are important.
Gotcha. We have some questions about neuropathy. For those with trigeminal neuropathy, can it still be caused by a compression and therefore make you a possible candidate for MVD?
So neuropathy is actually a different diagnosis. And the question is, what's caused your trigeminal neuropathy? And I do try and make patients who come to see me that have pain understand a bit different about the trigeminal neuralgia diagnosis and that syndrome, if you will, versus what happens with the trigeminal neuropathy. And neuropathy usually arises from a different type of nerve injury, not the demyelination caused by vascular compression. That's a very, very specific entity. Other injuries like a viral infection of the nerve, like a herpes zoster infection, shingles. If you have shingles of the face, you have a different problem. You have postherpetic neuralgia and you have a trigeminal neuropathy. You may have vascular compression and you may have an induced trigeminal neuropathy by previous treatments like a rhizotomy or radiosurgery that may produce a neuropathy. But if you have a primary trigeminal neuropathy like a postherpetic neuralgia and you have a herpes zoster infection and you have a problem with the nerve, an MVD probably is not going to help.
Gotcha. Okay. Kind of piggybacking off of what you just said about the myelin sheathing, can an MVD be performed successfully on other facial nerve disorders besides trigeminal neuralgia?
Absolutely. So, again, thanks to the genius of Dr. Janetta, the persistence and fortitude of Dr. Janetta, the diagnosis of hemifacial spasm, which is where you have unilateral facial contraction uncontrolled in attacks that are very reminiscent of attacks of facial pain, except that instead of the sensory nerve to the face, this is the movement or motor nerve to the face, the facial nerve, that's caused by vascular compression of that nerve's, the facial nerve's root entry zone. And then Dr. Brown mentioned glossopharyngeal neuralgia, usually pain in the back of the throat and the back of the tongue. Same type of pain, swallowing or talking, eating triggers that pain. It's caused by vascular compression of the glossopharyngeal nerve at the brainstem, again, at the root entry zone. So yes, facial movements, hemifacial spasm, similar mechanism, glossopharyngeal neuralgia, another pain syndrome, very similar to trigeminal neuralgia, same mechanism. And all those three are amenable to microvascular decompression.
Great. Good to know. Thank you. I think we still have time for a couple more. So, since the trigeminal nerve is a sensory nerve, when patients are considering to have MVD, should they expect facial numbness after the surgery?
Well, that's a great question because what they expect and what they're told may be two different things. When they have a conversation with the surgeon in preparation for MVD, the risks that the surgeon should discuss include the possibility of facial numbness. And because, as Dr. Brown had actually pointed out, the adjacent nerves are also somewhat at risk. So facial weakness is a possibility. Loss of hearing or change in hearing is a possibility. They're not likely, and I wouldn't expect them. So when you ask, should the patient expect facial numbness, ideally with a microvascular decompression, you should not expect facial numbness afterwards, but you need to specifically ask your surgeon, do you plan to do a partial sensory rhizotomy, or do you plan to comb the nerve, stroke the nerve, squeeze the nerve, all of which are what Dr. Giannetta's slide showed. When he first did his microvascular decompression, he also added to that a partial rhizotomy. If your surgeon, for whatever reason, thinks that that's necessary, then you're going to wake up with potentially some decreased sensation in your face, decrease in pain sensation, decrease in the ability to feel a pin or something sharp touch your face. It will not be normal facial sensation. If you have a pure microvascular decompression where it's only blood vessel is moved off the nerve, whether you use Teflon or not, you should not develop numbness unless you've done something wrong to the nerve. The goal is to preserve 100% of normal nerve function.
We like that goal, Dr. Zimmerman. um, what do you see as the next evolution of MVD surgery? Will it go away or be replaced in any way?
So I will attack that in two different directions, yes and no. I would love to see it go away. If we could figure out a way to treat MVD with a cure to fix the problem, that would be wonderful. And there are two different directions for that. One is perhaps a direct direction, which would be if, let's say, endovascularly, we could move the blood vessel off the nerve without having to open up the head. And you can do some blood vessel manipulation through a puncture in the groin, going endovascular into the blood vessels. If we could get to the stage of having fine enough and sensitive enough material that could move a blood vessel off the nerve, that with a stent, that might be something that would be an option. Flow diversion to change how the pulsations occur through the superior cerebellar artery or whatever blood vessels offending or compressing the nerve will be another interesting aspect of future development. I always say that because I'm trying to be optimistic. I don't think that those are likely, but I do think that they are reasonable to think about. The other avenue of research is what I discussed before about the myelin sheath when I talked about central and peripheral myelin. I don't think we know for sure which is where the problem is, central or peripheral, although because multiple sclerosis and demyelination of the oligodendroglial myelin, that central myelin is so similar in their TN to vascular compression TN. I didn't want to get too confusing there, but it is similar. That there's probably a problem with the oligodendroglial myelin, that's probably where the demyelination occurs, and research directed towards reestablishing that, even in the face of vascular compression, would be ideal. So there are patients who have vascular compression who don't have trigeminal neuralgia. Well, why is that? Do they not have demyelination? Well, perhaps. Do they not have as much demyelination? We don't know. But maybe we could give enough myelination back through myelin research that we could help reverse trigeminal neuralgia due to demyelination without having to do vascular decompression. Because again, we see vascular compression in asymptomatic patients, and we don't know how that occurs. The last thing is future vision of MVD. I don't think it's going to go away anytime in the near future. The future vision for me and teaching my residents is how to do the operation without Teflon. Because I think if you want to leave the nerve as happy as it can be, it will not have anything touching it, and that's its normal state. There is really nothing touching the root entry zone in the normal condition. So no blood vessel, no Teflon, leave it alone. It'll be happier.
Gotcha. Well, Dr. Zimmerman, you have been so insightful. Thank you so very much for your time and knowledge sharing today. I know we have lots of other questions in our chat that we can send your way, and maybe we can do some broad answering and make sure that we get back to the community on those.
Sure.
But I do want to send, thank you so very much. And that'll conclude our presentation. And I invite you all to go back to the agenda and join today's remaining presentations. And thank you again.
Thank you, Stephanie, so much. And Allison and David and Dr. Brown, thank you all so much for putting together a great conference. I hope the patients get a lot out of this. I know that they will. There's not enough we can do to help educate and support the population, whether you've had TN and you're cured now, but you continue to fight the fight and support other people who still suffer, and whether you help support through contributions to the FPA or contributions to any trigeminal nerve or myelin research is very great. There's clearly a need. We don't have 100% of the answers. We're not 100% successful in surgery. And we love to find an answer that fits everybody. So there's a lot of work to do. But thanks for conferences like this. They give us great places to start and help patients. So thank you.
Thank you.